All right, it is 1 o'clock, so good afternoon, everyone, to our APIC Great Lakes August webinar. Today, we are going to have member presentations from National APIC. That was back in June. So just some housekeeping, please mute your line. And then if you have any questions for our speaker during the presentation, just drop it in the chat, and then we will ask when it is completed. And so after this webinar, and then along with our APIC Great Lakes Fall Conference, we have one more webinar tentatively planned for November 4th with a topic on NHSN rebaseline. We are still seeking a speaker for this topic, so TBD, but please save the date for November 4th. And then lots of emails have been coming out from Amy regarding APIC Great Lakes Fall Conference. Registration has been open. The event date is October 9th, 2025 at Eagle Eye Golf Club and Banquet Center, so same location as last year. And registration deadline is September 23rd. And I'm very excited to share that we have maxed out our capacity of 26 vendor tables. So there will be lots of vendors there. And we are asking for pictures from your team. So if you have fun rounding pictures, team bonding pictures, any pictures from your team, please share with us, either email to Denise or our APIC Great Lakes Gmail account so we can get that added into our fall event slideshow during the conference. And then coming soon, so watch your email for more information. Call for nominations for APIC Great Lakes Board in 2026. We have an open president-elect position, and then new for next year, there will be a director-at-large position, along with treasurer, membership secretary, and nomination committee. So watch your email for more information on that. And if you missed a webinar, don't worry. We record all of these webinars and then post them to our YouTube channel. And then presentation slides and any supplemental materials can be found on the APIC Great Lakes website. So there will be also an email, usually post webinar, that comes from Amy with informing you that the recordings have been posted and the presentation slides are posted to the website. And if you have any open position at your facility and you would like to post to the APIC Great Lakes webpage for recruitment, please email us at our apicgreatlakes@gmail.com. And attached here is the link to the board job. And for today's members presentation, there are no CEs available. And with that, I'm going to actually kickstart us today. There is going to be 3 board members, so myself included, plus Dorine Berriel-Cass and Jennifer Madigan, who received a free conference registration and attendee by the APIC Great Lakes chapter. And so we are just going to share a bit of our learnings from the conference with you today. So I will kick us off for that. So again, thank you, APIC Great Lakes, for providing me with a virtual APIC attendance registration this year. And I just want to share 2 presentations that among the many that I watched, but I wanted to share 2 with you guys for my takeaways. So the first one are just updates from the Certification Board of Infection Control and Epidemiology. So for those of you guys who missed this webinar and aren't aware, so CBIC is improving accessibility. They've implemented reduced exam fees for candidates based on their country of residence. And then there is the AIPC certification is now renewable through either the proctor examination or continuing education IPU. So that continuing education portion is new. And then what's also new is that if you participate in a formal mentorship program through a professional organization, and that is related to infection prevention and control, you can now earn 3 IPUs per year for your program participation for recertification. And then effective at the beginning of this year, so the CIC, the AIPC, and the long-term care CIP exams are now all delivered using forward navigation. So what this means, this is a new format where you the test taker can only progress through the exam in a linear sequence. So you have to answer each question one after another. You don't have the option to mark the question and then return to it later on to answer it. And the Advanced Leadership CIP, which is the newest certification, it was released at the beginning of this year. This Advanced Leadership Certification in Infection Prevention and Control is an assessment of your knowledge, skills, and abilities, and leadership and impact in the field of infection prevention and control. This is a portfolio-based assessment. And this application opens twice a year. So we already passed the first application period, which was the beginning of the year. And then the second application period is currently open and actually will be closed this Friday. The other presentation, which I really enjoyed, was called Passport to Prevention, so infection control considerations in the age of medical tourism. This presentation just talked about, what medical tourism is. So it's just the practice of when you cross borders to receive medical care. And in 2023, 1.4 million Americans actually travel outside the US for medical care. And the most common reason was because it was lower cost than getting that procedure done in the US. And the most common procedure that was sought abroad was actually dental procedures. And Mexico is the most popular country for medical tourism. And then they talked about lots of reported procedures and infection type associated with medical tourism. So there's cosmetic and plastic surgery procedures that are commonly associated with mycobacterium, resulting in surgical site infections. And then there's primarily bariatric surgery, some cosmetic surgeries, which they've seen them producing carbapenem-resistant Pseudomonas aeruginosa infections, and primarily liposuction and other cosmetic surgeries with epidural anesthesia resulting in fungal meningitis. And their investigation, many of these investigations reviewed, that there were infection control breaches, including improper instrument reprocessing, suboptimal infection prevention practices, and then possible contaminated water sources. And this is just one of the graphs they shared talking about the IP challenges in medical tourism. So this graphic dives into the infectious complications that are associated with medical tourism. It just shows a high level of the IP challenges that we see. So at the top, you see SSI, antimicrobial resistance, and contaminated medical products or injectables. And then at the bottom, we see more of the systemic risks that are driving these infections, that are driving these infectious complications, things like continuity of care issues, variations in IPC standards, and breakdowns in outbreak contaminant. So infections don't carry passports, and neither should our prevention strategies. So what can we do or advocate for? So these are some of the things, items that they, at the end of their presentation suggest we could start asking the patient about medical procedures and hospitalization abroad during intake assessment. We can educate our team members and patients about the risks of medical travel and what to look for. Screen patients for MDROs with high-risk procedures or who've had overnight hospitalization abroad. And then we can, in our surveillance and reporting, be on the lookout for these infections or develop, and these are more long-term things right here, develop trigger questions for the ED and outpatient teams to quickly identify travel-associated risks. And then encouraging, they said encouraging medical travel programs to pursue accreditation and regulatory compliance. And then last but not least, support cross-border collaboration between public health and healthcare facilities internationally. So those were my takeaways I wanted to share with you guys today. And then next up, I will hand it over to Dorine to share her learnings.
Thanks,
and Dorine,
Chau.
I will just advance your slides for you.
Perfect. Yeah, just sharing the Great Lakes picture with the Great Lakes t-shirts that were shared at National APIC. And they actually had an APIC chapter day, which was the first time they had that. So they encouraged folks to highlight their chapter, sit together at the opening and general sessions. And so we had a good turnout there. And I just highlighted the temperature on Sunday, the 15th. It was 111 degrees. So quite hot. Next slide, please, Chau. So my first day there was actually attending the chapter leader meeting, and they had an illustrator that created this slide, which touched on all the topics and things that were brought up there. But some of the things that highlight were Chau had already talked about CIC and ALCIP, and that the deadline is 8/15 if you are going to submit for that. But they also shared or got some clarification around the question of when I recertify, so say I recertified in March of this year, which means, I don't need to recertify for another 5 years, but when can I start counting those IPUs? So you can start counting your IPUs the day after you get notification that you have officially been recertified. So if you get that notice at the end of March, even though your CIC is good until the end of the year, you can start collecting those IPUs for the next round. Devin Japp did come and give an update on what's been going on with National APIC, and National APIC at that time of this conference had already submitted 9 statements to our government agencies. No surprise with all the changes that have happened between CDC and HICPAC. It's been a very busy year for our legislative arm of APIC. And then he said they're continuing discussions with Joint Commission regarding IFUs, our favorite topic, and just along the lines of how surveyors are trained and what they should look at during those surveys. And then they did highlight the chapter awards. So there were 3 chapters that had received the awards: the Baltimore chapter, the Ohio chapter, Central Ohio, and New York. And the chapter leaders that were also recognized also came from these 3 chapters. Next slide. So one of the presentations I was very much interested in was manufacturer's instructions for use, friend or foe. And the hospital that actually did the presentation on this was from Memorial Sloan Kettering, and they were talking about a piece of equipment that they had been using, and they had IFUs for it. And then there was some mechanical adjustment that needed to be done to the equipment that then required new IFUs. However, the new IFUs came very, very difficult to follow. And so they just decided to do a risk assessment looking at old IFUs and new IFUs. If you want to go to the next slide. So they did a risk benefit analysis, and they looked at the new MIFUs, and you can see that there were lots of risks with the new units. And then the benefit would be that when your Joint Commission surveyor walks in and asks you if you're following the IFUs, you can say, yes, I am. Then they looked at the old MIFUs, and the risk was not meeting the regulatory standards. However, there were lots of benefits. And so they had decided to stick with their old MIFUs for cleaning and disinfecting. And by the way, this was considered a low critical, or not critical, a low device for cleaning, disinfecting. It did not have direct contact with the patient or anything that went inside the patient. Next slide, please. So what was really interesting is when they came to the Q&A of this session, Sylvia Garcia Houchins, who used to be with the Joint Commission and now is an independent consultant, pointed out that this facility did not simply ignore the new MIFUs. And they did try to work with the manufacturer to resolve the conflict. And Sylvia did recommend that if IPs can't meet MIFUs, they should report it to the FDA as an unusable MIFU. And then this would get reported as an allegation of regulatory misconduct. And I did drop that site here on the last bullet if you've got that current situation at your facility. Next slide. One of the general sessions was the Aarons who produced the podcast, This Podcast Will Kill You. And they were wonderful to listen to. And, they said that they started this whole thing because they picked up that there was a real gap with research science and people that aren't scientists. And their goal was to demystify how science is done and to increase trust. And I think we probably all are feeling that mistrust in our current practices. But one of their quotes was, admitting what you don't know is an undervalued strength. And I think that's very important for all of us that work in infection prevention, especially coming off of COVID. We had many a moment where we didn't know, and we just need to let people know we don't know. We don't have the answer. Next slide, please. This is just a list of other sessions I would recommend, but pointing out that they were all great. And if you have an opportunity to check these out, please do. And that's it. Thank you.
Thank you, Dorine. And next we have Jenny Madigan.
All right, thank you. So again, just as the other presenters mentioned, thank you to APIC Great Lakes for allowing us to attend this conference. It was great, so we're happy to share some of our learnings. Okay, so I have 3 oral abstracts that I'm going to present today, and actually one of them was the same one that Dorine just presented. So when I get to that one, I'll talk just a little bit about that one. The first one I chose is Wash Your Paws Using Creative Canine Marketing and Therapy Dogs to Promote Hand Hygiene Compliance. And this one just struck me because it was different than normal. Plus, I love dogs, so it attracted me. What this health system did is they wanted to find a way to increase their hand hygiene compliance because they determined that messaging is just throughout the hospitals, everyone becomes fatigued with all the different signage and messaging that's out there, including messaging for hand hygiene. So the health system prepared a canine-themed marketing approach to engage their staff, and this was across 5 of their acute care hospitals. They used their therapy dogs in this marketing. They also had logo wear, so they had T-shirts, they had stickers, coloring pages. They were all branded with dogs and canines. And they had engaged their staff with trying to encourage them to buy the T-shirts, and had a big education session where they used Wash Your Paws as the slogan, where healthcare providers would wash their hands together with washing the paws of the therapy dogs. So it was just kind of something fun, different approach to hand hygiene. Before this intervention, they had a hand hygiene compliance of 82.9%. This was for the preceding 4 months, and they had a large number of observations. After this intervention, they had a hand hygiene compliance of 84.6%. That was the month in which the intervention kind of culminated, and also the following, after that culmination, the following like 3 weeks. Then after that, the next 3 months, it actually increased to 85.7%. Again, large number of observations to look for hand hygiene compliance. It didn't seem like a huge percent increase when I just was looking at it, but they did do a statistical analysis on it, and it was statistically significant with a p-value of less than 0.001. So they did find that they not only increased hand hygiene compliance, but it also they were able to sustain it for over that next 3-month period. And next slide. The other abstract was, "Can you escape the room? Engaging staff in environment of care." This health system wanted to find a way to deepen their staff involvement, to increase their knowledge, attitudes, and skills around environment of care, or EOC compliance. So they set up a mock patient care unit, and they replicated some of the common infection prevention and safety findings that we see during environment of care rounds. They had then their unit and ancillary leaders come into this mock-up unit and had them decipher all of the risks in the environment. They awarded the leaders that had the highest percent of being able to recognize different issues. Also, whoever was able to escape this room the fastest. So they did incentivize leaders in participating. Their baseline EOC compliance was at 74%. And then after this intervention of using this EOC escape room, their compliance with EOC findings was 80%. And they also sustained that over the course of another 6 months. So they also found that engaging staff in a little bit of a different way of learning EOC helped them sustain increased compliance with EOC measures. At the APIC conference, there was an escape room. It was actually, I was not able to sign up to go through the escape room. You had to sign up ahead of time pre-conference, and the slots filled up very rapidly. So I was not able to partake in that. But I know escape rooms and this concept was kind of a big thing overall at the conference as a way of engaging staff. And next slide. And then this oral abstract was the same one that Dorine presented. So we do encourage you to go look at this one. Manufacturer's instructions for use, friend or foe. I don't need to repeat what Dorine had mentioned. As she mentioned that there was a large device manufacturer who had change in their device, updated their device, which then led to updated IFUs. So really it went from cleaning this device with just being able to clean it prior to the prior IFU was with just using a quat ammonium wipe, a one-step process. Now this new IFU said that they had to have a 3-step process of using bleach, deionized water, lint-free cloth. So we know that once you add all those different measures, compliance and feasibility is going to be lower. They went through the whole risk analysis that Dorine outlined, and then they decided to stick with the old IFU. And so it was interesting to see how they went through that risk analysis. I was still hesitant on whether that would work, even though the prior Joint Commission leader said that it had commented on that they had used this risk analysis and that was the right way to go about it. I know that in the past we've done some risk assessments in the hospital before, and Joint Commission always was still sometimes they would accept that and sometimes they would not. So I guess I'm always hesitant not to follow the IFUs, even though in this case it definitely seemed warranted. You can go to the next slide. APIC's IFU has been very involved with IFUs and trying to improve IFUs through the manufacturers, and both the presenters so far have talked a little bit about this. Just going over very briefly what has been accomplished. This was also talked about at the national conference in several different sessions. In 2022, APIC had a focus group. They shared their feedback from this focus group at the next conference, the annual conference in 2023. Then they had an APIC survey, and this was a large APIC survey across the country, across the world, asking to gather information about IFU issues. From that, there was a 2024 manuscript that was produced, and that was a large 28-page manuscript. The title is listed here, and we have some some infection preventionists within our own state who were very involved with that, whether they were on the board or public policy committee. Next slide. So the manuscript called for action, and these were the following things that APIC had called for. So they wanted tools to be developed. They highlighted problematic IFUs and getting the attention of the manufacturers and FDA, engaging policymakers. I'm not going to go over this in detail because it would take a long time, but just wanted to outline to you that APIC did recognize all of the faults that we're seeing across all of our healthcare systems. And next slide. Then in 2025, APIC sent a letter to the Joint Commission asking them to modernize their compliance with IFUs during the survey process. So they wanted the Joint Commission to differentiate between non-compliance with policies and practices and situations in which a risk assessments have determined an alternative cleaning, disinfection, or sterilization method as appropriate. And so this can be a huge difference in that this is really saying that if you have that risk assessment and you're determining that you have an alternative cleaning method, disinfection method that's appropriate, that Joint Commission would be able to evaluate that and differentiate whether it was an actual non-compliance or that the infection preventionists had determined that it was a safe practice. And then also the letter wanted to reassign IFU findings from IC to EOC or leadership chapter. So I think we would all like to see something like that. I know we just had a Joint Commission survey. We actually were cited for an IFU issue. It did end up falling under IC. So I don't think this change has been made yet. And then something to be anticipated is APIC's toolkit for modernizing medical device instructions for use. This will give definitions, algorithms to use, risk assessment templates, risk benefit matrix, case studies, and it's going to be engaging with other national agencies. And I believe that was my last slide.
Thanks, Jenny. And next up, we have Jennifer Jones.
Awesome. Thanks, Chau. So I am Jennifer Jones. I'm one of the infection preventionists at Corewell Health, Helen DeVos Children's Hospital. And this was my poster from National APIC, really looking at a cutaneous aspergillus outbreak in our neonatal intensive care unit. Next slide. So huge thanks to the co-authors. So this was really a multidisciplinary approach with facilities and IP and nursing, industrial hygiene as well. So we were notified of 2 confirmed and 1 suspected hospital-acquired Aspergillus fumigatus infection in babies in our neonatal intensive care unit. These 3 babies were housed in our small baby unit, which was in a shared nursery or multiple shared nurseries. And so we consider hospital-acquired fungal infections as never events. And so when we got notification of the first event is when our outbreak investigation started occurring. So we brought together this multidisciplinary team to really look at potential sources of transmission. So we used case study methodology, looking at chart reviews. We did send whole genome sequencing. We did send our isolates for whole genome sequencing to the state on 2 of the isolates. The 3rd baby, because of that baby's size, the amount of tissue that was collected on the punch biopsy was very small. And so we did disclose that that our lab told us to interpret those results with caution. So which is why we say that it was suspected and not confirmed. We also were unable to send that specimen for whole genome sequencing. Next slide. So when we looked at our initial chart review, it was revealed that 2 of the 3 patients were delivered in the same operating room, and all 3 patients were admitted to the same delivery isolate. So we have at Corwell Health Butterworth 2 units in our center tower that are our OB units. And then on our 3rd floor, there's a connecting hallway to our NICU, which is housed kind of in 2 different buildings connected by a long hallway. So one half of the unit is private rooms on the children's side, and then one half of the unit is in shared nurseries on like the west building. So we have delivery isolates that these babies are placed into to be transported from labor and delivery to the NICU. Our whole genome sequencing results did not indicate any plausible epidemiologic linkage, with the caveat that we were told that fungal whole genome sequencing is not as robust as bacterial whole genome sequencing. And so we again took those results with caution and just proceeded as we typically would with an outbreak investigation. As you can see in the figures below, figure A or figure 1 is our timeline of events between the 3 babies. So it's when the baby was born, where they were delivered, and then which area of the NICU they were admitted into. And then again, the date that the punch biopsy or skin culture was collected. Figures 2 through 6 indicate kind of lapses in the environment of care audits that we had seen when we went out into the unit and kind of walked the spaces on where the babies were delivered into where they were admitted into the NICU. So you can see in figure 2, the manometer is showing us that we had shared nurseries that were negative pressure that should have been positive pressure. In figure 3, it indicates we had drywall damage. So we had holes in our walls of our clean utility room where our delivery isolates were housed. And then we just had dust and debris kind of around the corners of the room. The next figure shows tape. So our standard at our hospital is that tape should be single patient use and stored covered, either in a drawer or in a plastic bag. And I'll admit we found tape everywhere. So we found it in nurses' pockets. We found it on bedside counters. We found it in drawers. We found it at the nursing station. Again, I'll just be super transparent and say this was a time when our supply of our current tape was on limited supply or back order. And so the clinical teams had pivoted to multi-patient use tape. And so we had put in some interventions to say, okay, we might have to have it be multi-patient use, but it still needs to be accessed with clean hands and stored appropriately. And then the 5th image or figure there shows dust on surfaces within our nurseries, and then duct tape or painter's tape on the floor there, showing that we had non-intact flooring. So we did not find just like one source of possible transmission or like one slam dunk. We had multiple opportunities for improvement and have mitigated all of these findings. Without giving too much on linen, Brianne's presentation next will go all into linen, but linen was a huge, I'll say, opportunity or part of our investigation. And so again, Brianne will go into kind of our implementation and intervention there. If anyone has GE giraffe beds at your organization, those IFUs are pretty lengthy in how those giraffe beds or isolates need to be cleaned and disinfected. And so we had done work previously on creating standard work and making sure our teams were following that compliance with cleaning and disinfection process. But we again went back out and did additional audits to make sure that we could validate that our unit aides were cleaning and disinfecting them appropriately. We did do multiple air and surface samples, trying to isolate Aspergillus in our hospital system. We did have one air sample in a hallway from a loading dock to our clean linen room. And then we did have one air sample within the NICU that grew a different species of Aspergillus. Kind of all of these findings have helped us to develop an internal fungal surveillance program and then a standard response to how anyone on our team would respond to a fungal outbreak or a hospital-acquired fungal case. Next slide. So just in conclusion, health systems should have a fungal surveillance program in place. Due to the risk to any patient, one case of a hospital-acquired fungal infection should be investigated. This again was just a multidisciplinary approach between facilities, industrial hygiene, the clinical teams, IP, and then leaders. And then again, without that one source of transmission, we had implemented multiple improvements and all of our kind of fallouts have been remediated. That's it. Thanks, Chau.
Thanks so much, Jen. And then next is Brianne.
Thanks, Chau. Hi, everybody. My name is Brianne Bachman. I am one of the infection preventionists at Corewell Health in Grand Rapids. And as Jen indicated, we kind of work together a lot on this project. You can go ahead and go to the next slide, Chau. This poster essentially covered the other arm of our investigation, which was all things linen. We felt like that alone was a big enough project, and it not only affected all of our patients in the NICU, but all of the process improvements that we put into place with healthcare textiles benefited all of our patients throughout the hospital, as we all received the same linen from an outside source that gets distributed throughout the hospital. So the background is going to be very similar. It was this case of 2 confirmed and 1 suspected hospital-acquired aspergillus infections, cutaneous aspergillus infections in the small baby unit that led us to do this deep dive. So for our methods, when looking at linen, we did infection prevention environment of care audits, both on-site within our hospital and at our third-party laundry facility. We did end up doing linen culturing. And as Jen indicated, we did environmental air sampling at on-site here within the hospital throughout different locations where linen is transported and stored. So next slide. So all patients utilize linen reprocessed at our third-party facility. The NICU uses linen that then is sterilized on site. We ended up looking at and culturing 20 pieces of sterile linen of varying types. All ended up being negative, thankfully. We did look at 65 pieces of non-sterile linen of varying types, and again, no pathogenic organisms were found, which made us feel a little bit more comfortable. But as you can see through some of the other pictures in the figures and through the environment of care audits, we identified many different opportunities when it came to trying to ensure that our linen is clean and safe for all of our patients. Figure 1 does show our linen sample strategy, which we used, and looking at the 3-2-3-2 snaking pattern for collecting those samples from the linen. As Jen mentioned, we did get 1 environmental air sample that was collected in the hallway adjacent to the loading dock, which you can see the picture of the loading dock in figure 2. We have downtown in Grand Rapids, we have 2 different docks. We have one that is generally a supply dock where all of our clean supplies and a number of other things are number of other business items are conducted out of. And then we have this loading dock, which is our generally soiled loading dock. That's where all of our waste goes out, biohazardous, dirty linen. The morgue and funeral services use this dock. So it was not a very clean dock. This happened to be the dock where our clean linen was also delivered. So finding that positive air sample in the hallway adjacent to this loading dock really helped to support our argument for moving clean linen delivery from this dock to our other dock to try to maintain cleanliness. We also found during environment of care rounds that there were some gaps in the maintenance of our linen carts or covers. We found a lot of dusty carts towards the bottom there underneath the last shelf, and then a lot of the linen covers we would find ripped and then potentially exposing linen to dust. So we did, again, using audit tools, identify gaps in transportation and of storage where linen was identified. So a few of the other interventions that we implemented were removal of the outside transport covers prior to storage in our clean linen room. So after they would get pulled from the truck to the clean linen area, that's when the outside transport covers would get removed. The clean linen cart would get pushed into the clean linen room. And then when that linen was to go be distributed to the floors, a new cart cover would get put on top to maintain that cleanliness. We also looked at, through the use of those audit tools, the CDC ICAR tool for healthcare linen was probably the most helpful tool that we used. There were a number of things to be identified, both at you can take it with you to your offsite laundry facilities, but also utilize it within house to look at different areas and make sure that you are keeping linen as clean as possible. So one of those things that was identified through the use of those audit tools was to look at and establish a monthly cleaning cadence for linen carts and covers that are stored on the nursing units, because we didn't necessarily have any. And so to try to help with making sure that we're reducing contamination of those covers that are touched quite frequently, and that to also help address the dust accumulation. Next slide, please, Chau. So our conclusions were having an infection preventionist with dedicated responsibility to linen services is very important to provide a collaborative approach to infection prevention sustainment. Jen and I learned so much about linen, and we really have to give a shout out to a number of the co-authors on this poster, Dave Roselle, Chase, and Kavitha, because they walked hand in hand with us. They made some major changes over a holiday weekend, no less, to make sure that we were delivering to the clean dock and keeping our linen as safe as possible for all of the patients within our hospital. The application of the healthcare tools can be useful to evaluate processes at both third-party laundry facilities and within hospitals. They can help identify gaps. And we encourage making sure that you're getting into your third-party laundry facilities. We've been going at least yearly, but within Grand Rapids, we've collaborated with some of the other healthcare facilities to ensure that essentially we're going quarterly. And sharing all of our reports and findings to just make sure that we understand what's going on in the third party facility that does have a major impact on our hospital. So that is it. And we included a number of the references and the tools here.
Thank you, Brianne.
Thanks,
And
Chau.
our next presentation is from Abigail.
Everyone, good afternoon. Can you hear me okay?
Yep, I can hear you.
Okay, wonderful. Give me 1 second. I'm just adjusting my audio. Okay. Can you still hear me?
Yes.
Okay, thank you so much. Sorry, not sure what was going on with my laptop. Good afternoon, everyone. My name is Abigail Ruby, and I will be presenting on behalf of our hand hygiene committee and some of our IP members, a multidisciplinary project that really started to recognize unit-based recognition for hand hygiene success. And it's something that we call our Hand Hygiene All-Star Program. Next slide, please. Okay, this is just our team who primarily worked on this. So I just want to take a second to recognize all of them who are listed, and also our former chief nursing officer was really the power behind this, and it was her idea to implement this. which I'll talk about a little bit in my presentation, but a lot of the success that we've had for hand hygiene at Henry Ford Hospital has really been through our leadership support. So we're really lucky to have her and all of our members. Next slide, please. Some of the learning objectives that we hope that the APIC members took away, and hopefully all of you do as well in this presentation today, is really how to develop unit-based recognition program, how you can integrate your hospital executive leadership into these programs, which really reinforces the importance of hand hygiene. I'm sure we can all relate to feeling a little burned out as IPs to constantly talk about hand hygiene. And sometimes when it comes from a leader or just someone different, it can hit a little harder with our team members. So hopefully you get something out of that today. And then, of course, really just how to foster engagement and pride. Many of us do not have large budgets to do elaborate things for hand hygiene. And so I think you'll see as I work through these slides that this was a really simple idea that was really inexpensive, but it really has caused a lot of chaos on our units in a great way, with them being competitive and really wanting to stay on top of their hand hygiene. Next slide, please. So just a little bit of background. All of you know that hand hygiene is an important tool in preventing the spread of infections. And of course, sometimes we see dips in our compliance, and there's always competing priorities. Our clinicians are very busy, and as all of you know, there's so many hand hygiene moments that go into the clinical workflow and patient care. And so we really wanted to look for ways to re-engage our staff, have some new messaging around hand hygiene, and incorporate more positivity. We were talking a lot about our gaps and things that we needed to improve on, but we weren't doing enough recognition when we did an assessment of our current program. So the whole goal of this is really to highlight our successes and also, again, promote that very friendly competition on the unit. And I just want to take a moment to note as well that at Henry Ford Hospital, we have a two-tiered hand hygiene program. So we have staff observers, which are hired students who have no affiliation with Henry Ford Hospital. They're completely external, and they act as our secret shoppers, collecting data throughout the hospital. So that's really what we used as the baseline for our data. And then our second tier of this program, which was not considered for this presentation, is our coaches data. And those can be Henry Ford Hospital staff, primarily our frontline workers who are supposed to coach and have a verbal speak up for our hand hygiene. Next slide, please. All right, so we talked a little bit about our stealth observers, and that is the data that we use for this competition. All of our stealth observations are loaded onto a dashboard. And so each month we would look at the prior month's data to make sure that, we were capturing all of our units who would be considered to be an all-star. So some of that criteria was making sure that they had at least 25 stealth observations. And then we would really filter it down by percentage, looking at who had the highest compliance. We would notify the winning unit or department and let them know that we'd be hosting a little award ceremony. At that time, our chief nursing officer would go to the unit with some of our other executive leaders, as well as the infection control team, and they would get a trophy presented to them. We would also hire a photographer within our PR team to come take a couple professional photos, which we would then use in some of our interfacility communication, as well as huddle boards for additional recognition. And we would have the CNO just read a little blurb that would say, their overall compliance, how many observations they had, and, give them that recognition before taking the group photo. And we did this monthly. So this really became something that the staff looked forward to. And I think the news traveled fast, and it, again, really promoted friendly competition. When we looked at our data for the 6 months pre-implementation compared to the 6 months post-implementation, we were really happy with the results, which we'll get into. Next slide, please. So since our implementation of this All-Star program, we had 10 hand hygiene All-Star winners. And this data isn't current, of course. This was what was presented at APIC, so we've had even more since then. And 1 month, we even had a tie. So that was really fun to be able to celebrate 2 All-Star winners. If I can draw your attention to the center of the slide, you can see our trophy there, which we got on Amazon. It even came with some engraving. It just says Hand Hygiene All-Star. I think it retailed for about $16. So, with a very small investment, we were able to have a lot of fun on our units, and our nursing and clinical staff love trophies. So this became something that was really fun for them. And you can see what our ceremonies look like. We would have them on the units with the teams gathered for the quick photo, the trophy, and then of course the certificate. And it made it much easier to do this on the unit because then we weren't taking any of our clinical staff away from patient care. And I would say each ceremony would be less than 10 minutes. So we were very respectful of their time. Next slide, please. Okay, I know I mentioned we were happy with the results, but we'll finally get into some of that data here. And so we had an increase in 11% when we first started doing this in the 6 months post-implementation. So this really helped us drive our compliance up. We kind of felt like we were at a standstill and we weren't seeing a lot of movement with our hand hygiene. Since then, it's continued to increase. So we have also added in a co-star category, which you can see on that trophy on the left-hand side. So we were getting such high compliance from our nursing units that sometimes we would have, 99.2% on one unit. We'd have another unit that would maybe have 98%. So our CNO came up with the idea to have a co-star recognition. So now each month we've been doing an all-star as well as a co-star, which also creates even more of that friendly competition. Those who won the co-star award are pretty excited to hopefully become an all-star one day. And it's also a way, I just think, for additional recognition, especially if they have that high of compliance. So again, we're having fun with both of these. Next slide, please. So in conclusion, I think that having this has really been a positive thing for our organization and our hospital. It's really re-engaged staff around hand hygiene, and I think everyone's mood and discussion around it has been much more glass full instead of empty, and has really made people see hand hygiene as something that's fun. Of course, we'll continue to do this, and I'm sure it will evolve with time. But one of the things I think I mentioned in the beginning was having leadership support is really important for the success of this, which I think has also really made our clinical staff feel important when they win this and they see someone from the C-suite coming to deliver that trophy. So lots of success here with our multidisciplinary team in a really nice way to highlight hand hygiene. Next slide, please. This is just an overview of our poster, but otherwise that concludes my presentation, and thank you so much for having us today.
Thank you, Abigail. And then next up is Claire, also from Henry Ford.
Yes, thank you. Can you hear me okay?
Yes, I
I
can
see
hear
some
you.
nods. Thank you. So this is another poster that our team had presented. I guess to introduce myself. My name is Clare Shanahan. I work as an infection preventionist at Henry Ford Hospital in Detroit. I work with Abigail. So this is another project that we were working on that we were able to share at APIC this year. Our poster's title was Leveraging the Electronic Medical Record to Avoid Hospital-Onset Clostridioides difficile infections. Next slide. I think we have some of our co-authors listed on there. So just to recognize some of the other people who are contributors to our project and our poster. And next slide. So our learning objectives from our poster that we had shared with APIC were that we hope to define some of the barriers to early C. diff testing. We also wanted to show people that you can utilize the electronic monitoring system to build a report to identify patients who are high risk for C. diff infection. And then additionally demonstrate the benefits of collaborating between infection control and nursing so that we can increase the early detection of C. diff cases in patients when they're admitted. Next slide. So background, as I'm sure this group is aware, C. diff is a pretty common HAI, especially at our location. So if we are not if we're not catching it early, then it has the potential to spread and persist within the healthcare environment, which can obviously lead to a lot more issues down the line. So our facility or institution as a whole actually has a nurse-driven protocol for C. diff testing, which empowers nursing to initiate testing and isolation at the first clinical indication. We'll get into it in a little bit in the future slides about what we consider the first clinical indication. But this protocol was existing, but we were realizing we were having not that great compliance with the protocol itself, or in talking to nursing team members, we realized that they weren't aware that they were able to order C. diff testing upon admission. So there was definitely some gaps in the process, and we wanted to find a way to improve adherence to the protocol. So we came up with this report that we will share with the group to help identify patients who met criteria for C. diff testing. And ultimately, our goal was to reduce the number of hospital onset C. diff infections in our hospital as a whole. Next slide. So as I mentioned, we utilize the electronic medical record system to create a report, which essentially pulls the recent stool documentation for every inpatient within our hospital. This report is run daily by each of the infection preventionists on our team, and we're essentially just screening for patients with any unformed stools documented within the first 3 days of admission. As I mentioned before, we have our criteria for testing in those first 3 days. Essentially, our criteria is saying if a patient has any occurrence of an unformed stool, so it's mushy, loose, or liquid watery, any one occurrence is enough for us to send that sample according to our hospital protocol. So through using this report, we were able to identify any patients who had stools documented meeting that consistency, and we were able to quickly check to see if a C. diff test had already been ordered for them, and their location, what calendar day of their admission, and a few other factors. So obviously I couldn't include a screenshot on the slides of our actual report given patient information, but this is just kind of a glimpse of what the report looks like and what the columns read as. And like I said, we run this every single day, and then we filter it down to the areas that we cover, and each IP follows up on it individually. Next slide. One of the ways we wanted to measure if this was impactful is we wanted to look at the percentage of our hospital onset cases that had unformed stools during the first 3 days of admission. And we were going to compare the 12-month pre-intervention to the 12-month post-intervention period. Essentially, what we're looking at there is we're looking to see how many of our hospital onset cases had missed opportunities for earlier testing. So our hope was if we saw a decrease in that percentage, that meant we weren't missing as many opportunities in cases that were later classified as hospital onset. And then additionally, we were looking at our total community onset C. diff infections that were identified and comparing the values for the pre-intervention period to the post-intervention period, just to see if we were testing and identifying more of these infections upon admission. Next slide. So our results, we had a lot of success using this report. So we did see a decrease in the percentage of hospital onset cases with those unformed stools in the first 3 days of admission. It went from 38% in our pre-intervention period to 24% during our post-intervention period. That's overall looking at that period as a whole. On the graph on the right-hand side, you can see we just broke it down to smaller increments. The lighter purple line is our pre-intervention period. So you can see that is, for the most part, higher, seeing a higher percentage of hospital onset cases with unformed stool compared to our post-intervention, which is that darker purple line. So we were definitely successful with that, that aspect. Next slide. And then we also saw an increase in the number of community onset cases that we were identifying. So it went up by 40%, with 229 in our pre-intervention period compared to 322 in our post-intervention period. So at least we knew through using this report, we were pushing for more testing and more of these community onset cases to be identified. Next slide. So in conclusion, we found that using this report every day, we've helped to increase the awareness of and the adherence to our C. diff testing protocol. So it's really helped nursing better understand what the expectations are for C. diff testing and the role that they play. This process has also allowed each of us IPs to collaborate closely with our nursing units and provide real-time education relating to the C. diff testing. So this will help us break through any barriers with either just understanding of the protocol or any issues or specific situations coming up with those patients about what might be preventing them from sending that C. diff sample. And then through leveraging the technology available within our electronic medical record system, our facility was able to increase our early detection of the community onset cases and avoid these cases being misclassified as hospital onset cases down the line. One more slide. And then this is just our poster overall that we had shared at APIC. And then my information in case anyone has any questions. Thank you.
Thank you, Claire. And last but not least, we have Eileen Thompson.
Hello, everyone. I am Eileen Thompson from Corewell Health, and thank you for having me here today to present our poster. I'll be sharing how my healthcare system enhanced high-level disinfection and sterilization practices across our 8 hospitals in our East region by fostering intentional and interdisciplinary collaboration. Next slide, please. Oh, one more. There we go. So this is our overall poster that I presented at APIC. So I wanted to include this in case anybody wanted to go back and look at it later. Next slide, please. So effective high-level disinfection and sterilization are not just technical tasks. They are fundamental to patient safety and critical to preventing healthcare-associated infections. In the face of increasing complexity, staffing challenges, and evolving regulatory expectations, it's more important now than ever to ensure that our sterilization and disinfection processes are not only compliant, but also consistent, sustainable, and team-driven. So next slide, please. So what did I do? Well, my healthcare system comprises 8 geographically linked hospitals, each with their own unique workflows, equipment, and culture. So I recognize that despite our best intentions, we had variability in protocols, communication gaps that were occurring between infection prevention, the OR, and the sterile processing department, and that was creating risk. Additionally, our flash sterilization was overused, and event reporting related to sterilization concerns were rising. And perhaps most importantly, staff confidence in processes was inconsistent. So I knew something had to change, and that would require a system-wide approach. So what I did was I formed a multidisciplinary team made up of infection preventionists, OR leaderships, SPD managers, and other key players from each hospital. And this team met regularly to align our goals, share our data, and develop targeted intervention. Our aim overall was not just to improve our metrics, but actually to foster a culture of shared ownership and open communication across all of our sites. Next slide, please. So how did we do this? This was our strategy. It included 3 core pillars. The first was protocol standardization. So we developed a unified high-level disinfection and sterilization protocols that were grounded in our regulatory standards and best practices, ensuring that expectations were clear and consistent across all of our facilities. The second pillar was tailored education and empowerment. So we customized training by role and department, and we emphasized not just the how, but more importantly, the why. And staff were encouraged to ask questions, raise concerns, and of course, contribute to continuous improvement. The final pillar was audit feedback loops. So our monthly audits were conducted and the results were reviewed. And the most important thing here is they were reviewed collaboratively. So the data was shared. And rather than using that data punitively, we treated it as a springboard for consecutive dialogue and constructive problem solving. Next slide, please. So what did this result in? Well, the results were pretty substantial. Over a 12-month period, we saw a 34% reduction in safety event reporting related to high-level disinfection and sterilization. Additionally, they had a concurrent 31% decrease in flash sterilization volume, indicating we had better planning and better adherence to our standard sterilization cycles. Notable improvements in cross-departmental communication and staff engagement were also observed. And we saw qualitative gains too. Staff across all of our sites were reporting greater confidence in their roles and a stronger sense of connection to the broader mission of infection prevention. Next slide, please. Oh, maybe there's back one. Nope. Okay. Well, I guess I have a little more to say still. So I wanted to just chat quickly about our key lessons that emerged from this initiative. So first and foremost, collaboration must be intentional. It's not enough just to communicate occasionally now and again. You have to have structured, reoccurring engagement between departments. Second, standardization will enable scalability. So if you have unified protocols, you will have less fragmented and less fragile improvement efforts. So the more you can standardize, the more you can work together, the better you can scale. And lastly, empowered teams really do drive outcomes. When your frontline staff understand the purpose behind their tasks and they feel heard, performance improves organically. So thank you so much. And this was my presentation at APIC. And I have my information below should you like to reach out and learn more. Thank you.
Thank you, Eileen. I apologize. I don't know how we missed your conclusion slide. But
It's okay. I might have forgotten to send that one over.
Well, thank you so much to all of our presenters. Fabulous presentations today. From someone that was not able to go to APIC, I really learned a lot, and you're all doing some amazing work. We don't have any questions in the chat right now, but if you do have a question, please drop it in the chat and we can ask it of one of our presenters. And in the meantime, Eileen, I have a quick question for you about your flash sterilization. So the hospital I was with pre-2020, we went to a special casket system that eliminated all of our flash sterilization. Is that something that you and your team are looking at, or even with that, you're still having some instances every once in a while of flash happening?
So the reason why I called it flash was specifically because it's, I have a feeling it's the same casket system that you went to. So we are using that style of system here. So this was actual like flash sterilization, not necessarily IUSS volume. So across the board, we wanted to really move away from as much flash sterilization as possible and rely on our standard trusted cycles.
Thank you so much.
Mm-hmm.
All right. We do not have any questions. So next slide, please. Thank you so much for joining us today. Later on this week, you will receive, and all the members will receive an email from our membership secretary, Amy. It will have the slides and the YouTube link for the recording. And then we will also be putting these up on our website later on this week as well. And then please register for our APIC Great Lakes Conference in October and send us your pictures. We would love, during the conference, we do a slideshow at lunchtime and before different, during breaks and that. And it's great to see all of the wonderful things you're doing with you and your teams. So thank you for attending today and have a wonderful day.